All right. I hope you can all hear me.
Yes, please.
All right. Okay. So it's been a long break. All right. So we're going to continue, and topic for this week will be investigations for the male infertility, which is semen analysis. But before we still move on to the semen analysis, the methods themselves, there's a lot of things we have to learn before we move in there. So I've said over and over again that once you go through this course, you should be a master in this game. It's not going to be just a matter of learning how to perform semen analysis, and that is it. If you do that, to be like a bench-trained scientist or person, okay, you must indeed have the capacity and the ability to understand everything about this test. And so, yes, we're starting semen analysis, but we still have a lot of things to get into before we go to the step-by-step methodologies. Let's see what it is. Right. So there are certain basic facts that we have to just get through. Some of these are basics, and therefore it means that you are aware or you are in the knowledge of it already. You will see that it is an investigation for infertility. And therefore, you must understand the concept of infertility. Before you can come to infertility, you must understand what is fertility, okay? All right, so what we can just say that fertility is a couple concept. I mean, it's not like one thing that is affecting one individual. No. Once you talk about fertility, then you are talking about a male and female coming together for a purpose of reproduction. Okay. All right. So you cannot be there on your own and say that you are fertile or infertile. The only way you can know whether you're fertile or infertile is when you've come together with your partner and with a soul reproducing, and whether you have a positive outcome or negative outcome will now determine whether you are fertile or infertile. Okay. So fertility is a couple concept. Infertility is defined as the inability of a couple to conceive naturally after 1 year of regular, unprotected sexual intercourse. So the key words have been bolded so that you can appreciate it. The inability of a couple to conceive naturally after 1 year of regular, unprotected sexual intercourse. That's failure to conceive after 1 year of unprotected sex. These are the ingredients of infertility. So if somebody has married for, let's say, 2 years, but the husband is staying somewhere, he's also staying somewhere, and occasionally they will meet, still doesn't meet the threshold for infertility. Yes, it is true that they have married for 2 years and there's no issue. But the fact is that they haven't had regular sexual intercourse. The concept is that the ingredients of defined infertility is the regularity of unprotected sex. Or let's say you are married, yet when you are having an affair, you put on condom. I mean, it also defeats the definition of infertility. So all those ingredients, the fact that they should have stayed for at least 1 year, and the fact that they should have be having regular, unprotected sexual intercourse. No, you don't, that occasionally you will put on condom, and the other time you don't put on, that also doesn't meet the threshold for infertility. So I want you to understand this concept. And it is important to know this thing because we are learning not for ourselves, but also to have the capacity to be able to also educate our clients. you must be also be have the right knowledge so that you don't say one thing and then a clinician also says something else. Then they will say, who told you this? They say the lab scientist. Where does he get that information from? Then it is also, but once you tell a patient something, he goes to a clinician, the clinician also says the same thing. Then you say, so you know this already. Who told you? I said, when I went to a lab, that's why, fine. The guy, he knows his job. He knows his or her job. Okay, so it is important to get the right quality information so that you don't mess yourself up when you have to, when the need arises for you to interact with a client. All right. So that's the full definition of infertility. And we know that it is in fact becoming a problem. And it's been recorded that for if you take the population of married couples, our 15% will always be seeking for will have to be seeking for help one way or the other for conception. Okay, but what it means is that if you talk about 15%, it means that one in six of every couple will at one point in time be suffering from infertility. Okay, that is the global record. So still on infertility, several disorders can cause infertility or subfertility. And we explain, as we move along, we explain the difference between infertility and subfertility. Okay. Now, about a third of cases are due to a female factor. You see, long before now, the concept was as if there is an issue of infertility, or if there is a couple have an issue for pregnancy, it is always assumed to be a female factor. But now, as we move along, it's going to be like 50-50. Okay, it's 50-50. But for purposes of this program, it's been put into three. The third is that 1/3 is a female factor. A third of the time is a female factor. And then another third is the male factor. The other third is a combined. So if you also separate the combined, where 1/3 is either, it could be the fact that it's both the male and female, they have a problem. Then if you also divide this one, then this person can also now come to add up to the third for the male and then the third for the female, and then it becomes 50-50. I hope you are not confused. I'm saying that technically a man's issue is 1/3, okay? And then the female issue is 1/3. And then the next 1/3, it's both the man and the female. The man, the male and the female, both of them will have a problem. So if both of them had a problem, then technically, what it also means is that 50% of the cases is due to a man, and 50% of the cases is due to the woman. Why it is also becoming important to know that it is a third and not 50-50 is the fact that, you see, there's also a component called unexplained infertility. Okay, where the man doesn't have a problem, the woman also doesn't have a problem, but yet the two of them are unable to have a child. Okay, once these two go their separate ways, the man is able to go and have a child. The woman is also going to have a child. However, when the two of them stay together, they never had an issue. So that's also called unexplained infertility. So in this case, once it's unexplained infertility also playing a role there, then it is also going to be difficult for you to say that it's 50-50. So I just want you to understand all these concepts. If you want to say it's 50-50, you should be able to explain it. If you want to say that it is a third and a third and a third, you should also be able to explain. All right, good. Then We also have primary infertility. It's when a pregnancy has never been achieved by a person, both the male and the female. So a man can have primary infertility when he has never had a child with anybody. The woman too could have primary infertility when he's also never had a child with anybody. Secondary infertility is when at least one of them had a child before. Okay, so that is all, and this is also will also be called soft fertility. When a woman has had a child before, but now he wants to have a second one or a third one, it's no more coming. That becomes soft fertility. Okay, all right. So soft fertility and then secondary infertility can be used interchangeably. So with the infertility, when to start investigations? Is it that you married, and as soon as you married, you start to see a doctor that you want to have a baby, and therefore that may also be wrong. So let's see the appropriateness of when actually to start investigations. Remember, by definition, we said that infertility is defined as inability to have a child after 1 year of regular unprotected sex. So you should have meet that threshold, because investigation, you are going to investigate for infertility. And so first and foremost, you should be able to meet the definition of the infertility before you want to go and investigate. All right. So what it means is that you should wait for at least 1 year before you start the what do you call it? You start the investigations. Okay, it will be premature to want to start to go and see a doctor only 3 months into your what do you call it? Into your marriage. You want to have a baby, you are rushing to see the doctor. I mean, that may not be deemed to be appropriate, medically appropriate. So that is so you should have been able to have been together for 12 months. And not just 12 months, just for the period, but should also meet the ingredients of infertility, that you should have stayed together, they should have been regular sexual intercourse, and you should be unprotected. Not a way, like I said earlier, where the man is staying somewhere, and then the woman also somewhere, and then occasionally you meet once, and then you are saying that you want to investigate for infertility. Okay. And it can also be shortened after 6 months of if the female partner is more than 36 years old, 35 years old. The concept here is that once a woman is 35 years old, the chances that there could be a problem is high. Okay, and so once the chances, it's like we advise that, let's say, after 40 years or 50 years, you should be doing regular PSA. As a man, you should be doing regular PSA after 40 years. But if your father or in your family, you have history of prostate cancer, you don't wait for the 40 years before you start the screening. I hope the point is clear. Even though the regularly acceptable arrangement is that as a man, you can be having your PSA screening from 40 years and above. If in your family you have regular, or even the common thing is about diabetes. All right. If you have a history of diabetics in your family, you should be doing regular sugar tests. You should be doing it. You don't wait until, let's say, you also grow before, or you begin to show signs of diabetes before you go and screen. All right. So it comes back to what I'm talking about. You are supposed to wait for 1 year, but if the woman is already 35, it is presumed that by 35, probably, if you are now also going to get into marriage, it means that the possibility of the woman having a problem may be a little bit higher, and therefore, straight away you can scale down the 1 year duration to about 6 months. If after 6 months, there is no issue. And of course, that one too, they should have been regular, unprotected sexual intercourse for 6 months. If after that, there is no listen, then you can leave. And then it can also be immediate if there is an obvious cause for their infertility or soft fertility. Okay, if you know that you have cryptorchidism, and I'm sure all of you remember the concept of cryptorchidism. If you have cryptorchidism, you have problem with your testes, and therefore the probability that your sperm production could be compromised and stuff like that. Why do you have immediately you marry? You may want to start the investigations so that you don't wait for even the 6 months prior. All right. So once there is an obvious cause or obvious cause of a potential infertility or soft fertility, then you can also start immediately. So as scientists, you should know these things. All right. That when do you have to start the investigations? It could be 12 months, it could be 6 months, it could be immediate, depending on certain conditions which we just discussed. So now we zoom into the male factor, the male infertility. Okay, the male infertility. So when should the man specifically also start? So when couples present with infertility, a comprehensive evaluation of male infertility is essential. You see, in those times, once a couple have an issue that there's no childbearing become a problem, invariably the woman who will be subjected to all kind of medication for, then the man will be having his own time somewhere. That is also improper. All right. So once there is an issue, once all of you agree that probably it's getting too long, let us start investigations for infertility. The man also has a role to play. Okay. And now, what is important? What is important is that because we want to investigate for what do you call it? Infertility in the man. There are certain fundamental things that ought to be done. One is the patient history. Of course, there's always the clinician who will be taking the history. But as a scientist, you should also be interested. You should know that a doctor will not just ask somebody to go to a lab once he doesn't have any basis. There should be a basis. And the basis for going to a lab, you should have taken some history. All right. If even for malaria, you will be asking questions. You have fever, when did it start? Do you vomit and blah, blah, all those things. And then the doctor will think, okay, from the history that I've taken, it is possible that he has malaria. Let him go and then do the malaria test. Okay, so there should always be history taking. And the history, as we move along, we take you through the essentials of the patient history. Now, of course, there should also be physical examination. And then from there, the laboratory investigation. Okay, so these are also the key things that must be done once you want to start investigations for male infertility. The patient history. You can obtain a lot of information from the patient history. And the key aspects, the key things to look out for in the patient history are the reproductive history, medical history, and lifestyle history. Let's see how that goes. What is reproductive history? Age of both partners. For example, if the man is already, let's say, 60 years, and he thinks that he doesn't have a child, straight away, doctor should begin to start something. So the reproductive history, just even the fact that the man is at a certain age and he hasn't had a child before and blah, 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 will begin to show that, is it possible that he has some testicular problem or something, then all those things will come in. So that's the reproductive history. And then previous pregnancies. Now you are looking at the man. Okay, so have you, yes, you are let's say 45 years old. Yes, do you have a child elsewhere? Say no or yes. Or even if he hasn't Have you had a situation where a woman have told you that she's pregnant for you before? So those previous pregnancies, it doesn't mean that the man who is pregnant, but the man may have impregnated somebody. All right, and that is also something that is worth noting. Okay, if let's say the man is 45, 50, he has no child, and nobody has ever told the person that he is pregnant for him, that all those things will begin to tell a story. And duration of attempts to conceive. So, like we said that you should have stayed with a woman for about 1 year, if a fresh marriage, before you go into start. And so duration of attempt to conceive is important. That for how long have you are now married? For how long have you made attempt to conceive and it's not coming? Let's 3 months. But the 3 months is too early. I mean, you don't have to worry yourself. Okay, right. So, and then appropriateness of coital habits. Appropriateness of coital habits or sexual practices such as frequency and timing of intercourse. You see, I'm talking about the frequency. And you said, that the man may be staying somewhere, or this is a person who is just a traveler. So yes, they are married. But how often does he even have sex with the partner? So the appropriateness, the sexual practice frequency is, and the timing. You see, at least you are a man, you should have a certain knowledge of ovulation. All right, so that you know that my wife has this menstrual cycle. You can, even if you are illiterate, you can have somebody to give you some health education on menstrual cycles, and you should know the period within which the woman may be ovulating. Then, yeah, so that the doctor should have the patient history taken should involve all these things, so that you know that they have stayed for 1 year, all right, but after all, they are not staying at one side, and even when they are having sexual, I mean, it's occasional, and then even on the occasional, the man comes in, he comes to spend 2 days, so it is the 2 days and he has sex. Meanwhile, most of the time he comes in once the woman is already just 2 or 3 days into the next menstrual cycle. How can that be? So all these things are important information that the doctor should be able to gather as part of patient history. All right. And then use of fertility safe lubricants. So you see, there are some men who think that, and you know, these days, and all of us are matured, and I'm free to say so. These days, some women, they think that, I mean, they want a tight, this thing, so that once the man is penetrating, the man will have, you know, that the woman is like a virgin or something. You see, and this time people are selling all kind of things. They say that if you want to become a secondary virgin or blah blah blah, and people are inserting all kind of things into their vaginas. All right. So if you're a man, sometimes the man too, once he's penetrating and having a challenge, you want to have some lubricant of a sort. Remember, forgetting that he wants to have a child with this woman. And then the woman to be using some medications that's making the place tight. Okay, and so the best approach to the man is to use a lubricant. So use a lubricant for you to be able to penetrate very well. Most of the lubricants are spermicidal. Most of them are spermicidal. So the lubricant that you are using to enable you to penetrate, that same lubricant is going to kill the sperm that you're going to produce. Understand? So all these things are important information that must be gathered during the history taking. So that even with this alone, you may say that you don't even need to even go and do a laboratory test. Try and correct some of the things that the person is doing that are inimical to conception. All right. And so just by redirecting the man, probably some of the so-called infertility issues will even be corrected. Okay. So that is about the reproductive history. Okay. Still on the patient history, medical history. So you should be able to ask. And I remember we talked about mumps orchitis. Do you remember mumps orchitis? Hello? Do you remember mumps orchitis?
Yes, please.
So, and that's the is it Jemrokutu or something? So if a child has ever, the person growing up remembers that during childhood he suffered from something like this, the doctor should be able to know, and that's the medical history. Oh, when I was a child, I had this Jemrokutu. Most of the time, even though it's a viral infection, but if it is not well treated, if it's not well managed, they can get into they can cause mumps orchitis, and that can also have devastating effect on the testicles. All the seminiferal tubules will all be eaten away, okay, and therefore sperms will not be produced. So these things are important medical history that must be uncovered. If the patient has undescended testes, and this one we know already, this is cryptorchidism. All right. So, and this are medical history. The doctor must have to know. Testicular torsion. I think we talked about all these things. Systemic disease. If the person is diabetic, okay, you should all know, because we know that diabetes can have some serious negative consequences on even erectile function, and then also on fertility. All right. So if the patient is also diabetic, if the patient has ever had sexually transmitted infection before, you should know, because most of the times some of these STIs are not properly managed, and they end up this is giving you epididymal orchitis and stuff like that. All these things can have effect on sperm production. Okay, if the patient has ever had trauma, especially in the groin area before, you should know. Surgery to report that if the patient has ever had surgery, because you know that in the pelvic area, anything, if there's ever been any surgical manipulation, anything there, it can also affect your reproductive health. Okay, and exposure to gonadotoxins. All right, so probably the person is using chemicals or something that he doesn't know. Okay, or you may even have been exposed to some chemotherapy as means of treatment. On all those things, we have effects on this. So these are also important medical history that must also be known by. And then lifestyle habits or behavioral modifications. The person is a smoker. All right, if excessive alcohol intake, medicinal and recreational drugs, the person's opioid abuse, and then cannabis, smoking, obesity. We all of us know how obesity can also affect your testosterone levels, and then even your erectile function. Okay, exposure to environmental hazards. We know that once, apart from varicose, once your job exposes you to environmental heat, where you get yourself exposed. Remember, we talked about where somebody would drive for several hours without probably taking a rest. If you drive for several hours without taking a rest, you expose, the seat becomes heated, and then you expose your scrotum to heat, and that will give you the scrotal hyperthermia, and then it can also have. But so all these things are important information about the patient, which must be gathered. Then, apart from that, there should also be physical examination, and these are all within the domain of the clinician. But I'm saying for purpose of this course, you should also be privy to some of this information, so that you and the doctor will also be on the same wavelength. All right. So physical examination, general appearance. You can look at somebody and you know that probably physically there are certain characteristics of a man which is not present. All right. So the general appearance is very, very important. Secondary sexual characteristics. The person should And then the body habitus. Habitus is the physique, your makeup. Okay, not the makeup that people do when they are going into for a TV show. No, your physique, as in your size, your shape, your build up. You can look at somebody and say, "Hey, this person there, I doubt whether you can even have a penis or something." You understand? That's just by the way. So those are general appearance the clinician should know. Then that's the general appearance. Then genital examination, the doctor should be able to examine the testicles, because there are some people who doesn't even know that probably they have within the scrotum there's even no testis. They may not even know. So a doctor will, or even if they know that one is there, one is not there. The doctor should be able to examine all these things. All right. And so by reviewing the patient history and the physical examination, then the potential cause of infertility can even be identified right at that point. After the patient history and then the physical examination, the doctor will be able to determine the most likely cause of an infertility. And then from there, for example, like as you said, the doctor could examine the patient, he know that, oh, he meets all the criteria for malaria. Then you can say, go and do malaria test. When the results come, you know that, okay, I thought as much. Okay, right. So the doctor can ask the patient to go and do the semen analysis or to do a medical laboratory investigation. He should, by reviewing the patient history, which you have taken through, and then the physical examination, which you have also done, by merging the two, the information there can give you a certain information. And the doctor know this one there, I don't think he has, it can produce good quality semen for me. So once the result come and it is bad, you know that, oh, me cried from the history and from the examination that I did, I knew that this is likely to be the case. Okay, so that is that. So we know that now you've looked at the physical examination and then the history. Then the next thing is appropriate diagnostic tests. So then we go to laboratories. With the laboratories too, the basic fundamental is semen analysis. So the major cause of infertility in men may be sperm abnormalities. And therefore, the best advice, preliminary advice, laboratory investigation will be to do a semen analysis. So semen analysis now becomes the primary investigation for assessing male infertility. Okay, all right. So then, could there be other laboratory tests? Yes. After the lab, if the semen analysis, that's the primary thing you do. If semen analysis results are bad, then there could be other investigations. Okay, those investigations will now include hormonal assessment. All right, it could include genetic testing. Remember that we said that some of the things that can affect sperm production is genetic. Okay, if somebody has 47, remember that 47 XXY chromosomes. That's the Klinefelter syndrome. Then, so if depending on what the doctor is suspecting from the history, from the physical examination, and then from the first laboratory test, which is semen analysis, which is also bad, then the doctor could say, okay, let me go and do genetic testing. Even though here we don't do it, but as students of andrology, you should know that there's also something that can be done to find out the genetic makeup of that individual. Okay. And then post-ejaculatory urine analysis. And I'm happy to mention that just last week, one of us, did a very good job, very, very fantastic job, where we saw that the patient's semen volume was low, and he asked the patient to take some water, wait a while, and then produce urine. And then the post-ejaculatory urine sample gave microscopy of more than 100 sperm per cell, which is a rare pointer, a biomarker, let me put it that way, a rare pointer to a possible reticular ejaculation. You understand? And that is so. This becomes either laboratory test, because post-ejaculatory urine analysis is not part of semen analysis. Remember, you said that the test that you are going to do when your semen analysis results is abnormal. Okay, so post-ejaculatory urine analysis becomes one of those other tests. And then, of course, anti-sperm antibodies. Okay, you mentioned that once you do a semen analysis and there are a lot of agglutinated sperms, you should be able to suspect anti-sperm antibodies. Okay, once you have anti-sperm antibodies, with the anti-sperm antibody, they cause the sperms to agglutinate. Okay, so those aggregated sperm cells will give you a signal that the patient could have anti-sperm antibodies, and there's a special test to detect anti-sperm antibodies. And then, of course, there could also be testicular biopsies, where remember we said that you could do some surgeons could do testicular biopsies. They take the samples to the histopathology labs, where they also now assess whether the testis is actually producing sperms or not. Okay, whether the maturation arrest and all those sort of things. So all these are other things that can be done, and they become necessary only when your basic fundamental test, which is semen analysis, is showing an abnormality. All right, if the semen is showing abnormality, together with the fact that your history and then your physical examination all were pointing to infertility, then you want to know the actual cause, then you'll be doing the other tests actually to be able to pinpoint the real cause of the infertility. Okay, so we said that when your semen analysis is abnormal, the outcome is not palatable. Some of the things that you may be doing will be the hormonal test. Hormonal test is recommended for all men with atrophic testes. Remember, we said that before the doctor may even ask the patient to come and do the lab test, you could have done some general physical examinations. That could also include examining the scrotum. So you could look at the scrotum and know that even the structure of the testis is not proper. All right, so that's atrophic, abnormally shaped testis. Okay, so once you have atrophic testis and then abnormal semen analysis, especially where you have a low sperm count, then you should be considering hormonal assessment. Okay. The endocrine assay should cover key hormones involved in male fertility. Okay, so that when you say hormonal assessment, or it's not like any hormone that you want to do. So the basic ones will be FSH, LH, testosterone, and then you may also include prolactin, because you know that prolactin is also produced from the pituitary glands. I know that pituitary glands is also the one that produces the gonadotropin releasing hormones. Okay, under the gonadotropin releasing hormone produce the FSH and LH. So if you want to know the functional status of the source of the FSH and then LH, you may add prolactin. Okay, if you add prolactin and the prolactin is high, then you could know that probably there is some sort of lesion within the pituitary. You can have an adenoma, prolactinoma, where there's an adenoma of the pituitary. And then once that happens, there's going to be hyperprolactinemia. And you remember that hyperprolactinemia have a negative feedback, okay, on the gonadotropin releasing hormones, okay, and for that matter on the hypothalamus, and then also on the pituitary. So all those becomes important information for the clinician to know why the patient, because once you have hyperprolactinemia, of course, it's going to give you a low FSH, because the prolactinemia is now going to give you a negative feedback where they're now going to less production of FSH and then the LH. Okay, so those are the important things that as lab scientists we should know. Once you know all these things, then you can make a very good input to the management of the patient, and your doctor will always admire you. Okay, all right. Abnormal hormone levels can provide comprehensive information about the potential issues with the sperm production and also help identify possible causes. So once you do the first place, you should have done your semen analysis. That's the primary one. The semen analysis have abnormal results. Then you do the hormones. Then once you do the hormones, you will be able to now interpret based on the knowledge of the endocrine control of spermatogenesis. All right, you have that information already. So once you do your hormone analysis, you can now also do a very good interpretation. Oh, now I understand why the LH and FSH are low. Once LH and FSH are low, technically testosterone will be low because the LH that has to go to the lady cells to cause the lady cells to produce the testosterone. So once your LH is low, it means that testosterone production will also be low. So you have FSH low, LH also low, testosterone low. Then you all of a sudden prolactin is also high. Then so low, there's hyperprolactinemia. Then of course there could be a possible cause of a problem within the anterior pituitary glands. Okay, all right, and so forth and so on. So once you do that, it makes you yourself become very happy with the result that you are churning out. Okay, all right. So now we are gradually zooming into causes of the male infertility. Okay, so you have done all these things and you are coming to a certain conclusion that the man has a problem. So once the man has a problem, the pivot, the center of the whole thing is the testis. Okay, because the testis does not produce the sperms. So if the sperms are not being produced, then either a problem, there's even a problem before the testis. Because for example, if the problem has got to do with the hormonal, if the hormones are not, the LH and FSH are not being produced, then it means that even before the problem, even before the testis, the problem of hormone listen has shown up. So it means that the problem is even pre-testicular, before the testicles. Before the testicles is a center. The testicles can be producing only with the influence or under the influence of certain hormones. The hormones are not coming. So will you say that the problem is due to the testes? Of course, no. So it means that if there's a problem, the problem is before the testes. So that becomes pre-testicular. Okay. If we move on and we say, oh, the hormones are being produced, all right, except that the testis is not producing, then the problem is testicular. Then you go back and then find out what is also wrong with the testicles. If the sperms are also produced, and instead of being transported along the line, there is a blockage within the tubules that medicine. Is it a problem with the testes? The testes are produced the sperm. They must go along the line. There is obstruction. Then are you blaming the testes? Of course no. So that also becomes post-testicular. And the lab scientist should have the capacity to be able to determine where the problem is likely to be. Is it pre-testicular? Is it testicular or post-testicular? All right. Remember one day I was saying that one of the things that the lab can do better is if you do urinalysis and then you see RBCs in the urine. You can, yes, you have seen RBCs in the urine, but you can go further and look at the morphology of the RBCs. If you look at the morphology of the RBCs, you'll be able to have an idea where they are coming from. Are they coming from the glomerulus? Are they coming from somewhere along the tubules? Are they coming from the bladder? Or they are coming from the urethra? A good scientist should be able to determine where RBCs in the urine are likely to be coming from. And once you have that knowledge and that understanding, it makes your work very, very interesting. Not just report, who cannot report RBCs in urine? Anybody can report RBCs in urine. Okay. But the scientist is the one who is now going to report about the morphology of the RBCs in the urine and then getting to know the possible source of the RBCs. Because RBCs coming from the glomerulus will have a different pathology than RBCs coming from the bladder and then RBCs coming from the urethra. They can have different pathologies. But if you just report RBC, who even an assistant laboratory technician will be able to report RBCs in urine. So if assistant technicians report RBCs in the urine, then a scientist, and probably even with masters, is also reporting RBCs in urine. So what's the difference between the two of them? So let's move on. So what I'm saying is that once you do your work very well, there's a problem. You should be able to know by the interpretation where the problem is, whether it is pre-testicular or testicular or post-testicular. All right. So like I mentioned, if you are having to do with hypogonadotropic hypogonadism, hypogonadism is where, remember we're talking about the gonadotropic, that is the hormones that impacts on the gonads. Which hormones impact on the gonads? These are the LH and the FSH. Hypo, that is low production of the LH and the FSH. So if you have low production of LH and FSH, that's hypogonadotropic. As soon as you have this hypogonadotrophic syndrome, technically, testosterone production will be low. Okay, and the gonadism, that the gonad is the testis. Their function will be limited, will go down. So that's also hypogonadism. So if you have hypogonadotropic hypogonadism, straight away it becomes a pre-testicular condition. And this is where I expect the scientists to know what will make you know that it's hypogonadotropic hypogonadism. Your LH, FSH, and then testosterone all will be low. And once all of these are low, then you should find out. That's why normally we advise that you add the prolactin. Because once you add prolactin, okay, and LH and FSH are all low, then straight away that there's something wrong with the testosterone, sorry, with their source of production. And so another factor there will be the prolactin. So once prolactin is high, then that will be the pituitary adenoma. The pituitary gland is like inflaming. Okay, it's becoming an inflamed. Once it's becoming inflamed, then it is giving cause to. So then somebody asks, but if it's inflamed and then one of its products is prolactin, why is it that the LH and FSH doesn't also become high? You see, and we said that once prolactin goes high, prolactin now becomes a negative feedback. And that's the catchword, because somebody says that, okay, if it is pituitary adenoma, you are saying that the pituitary gland is becoming inflamed and therefore it's producing its hormones anyhow. It's producing its hormones anyhow. Then you should, under that circumstance, you should expect the LH and FSH also to be high. But the catchword there is that once you are having high levels of prolactin, okay, the high prolactin now becomes a negative feedback, just as we talked about the inhibin and testosterone. Remember that high testosterone also becomes a negative feedback. All right, so that's what happened. That's how come now FSH and LH becomes very low. So with that understanding, that's why we did the andrology. So with that understanding, you are not just doing hormone analysis and just giving out the result to a doctor without you yourself understanding or knowing what it could mean. Okay, so you as a scientist, you have a good knowledge about these things so that the result that you are churning out, you can even interpret them. Okay, all right. Good. So testicular, of course, the testis is not producing. You could have a problem. And one of the possible causes is testicular cancer. Okay, so the testicular cells are becoming cancerous, therefore they cannot perform. Testicular trauma, if somebody may have caused a trauma, there could be an infection there, inflammation there, that will cause the testicular function to go down. Torsion, you know that one, that twisting of the spermatic cord, the blood supply to the testis will be compromised. and that could cause even necrosis. We've done all those things. And then varicocele, you know that this is veins, large veins that affect the testes, and for that matter, they bring in large volume of blood, and therefore has a tendency of creating high scrotal temperatures and all those kind of things. Infections, of course, orchitis. Infections could cause a whole lot of problems for the testicular functioning. And then, of course, this will show up as sperm abnormalities if you have an injury in all those. So once all these things are happening, you will know that, for example, you've done your hormones, everything is normal, and then you also see a lot of sperm abnormalities. Then this could be a testicular problem. Okay, right. Now post-testicular, and that brings into sharp focus the element of retrograde ejaculation, which we have done already. All right. So if the testis has produced, the sperms are supposed to go. However, instead of being moved out for them to go and do what they have to do, now the sperms are being reversed. The semen is being reversed into the bladder. Are you going to blame the testes for that? Of course, no. So that becomes a post-testicular problem. Okay, so retrograde ejaculation is a post-testicular cause of male infertility. Okay, so all those things, once you have this knowledge and you are doing any test, you have a better appreciation of the outcome, and you also be able to interpret them well. And then, because it is this interpretation that will also now shaping the management of the patient. All right, so that the lab scientist is now playing a role in the patient management, not just diagnostic, but also playing a role in the management because of the kind of knowledge that you have. Even if the doctor doesn't know, you with your high quality of knowledge in andrology and semenology, you can also advise the doctor that, okay, I'm suspecting this and that because of the ABCD. So can you do it this way? Then the doctor will know that you're also playing a key role in patient management. Right, so we talked about another post-testicular problem, which is anti-sperm antibodies. And that could lead to autoimmune male infertility. You see, and all of us know about autoimmunity, where the body is producing antibodies against self. All right. And you know that sperms are part of you, of the man. Sperms are part of you. And so if the body is now producing antibodies against an aspect of its own, then it becomes an autoimmune condition. So that's how come anti-sperm antibodies can lead to autoimmune male infertility. So now sperms are being produced all right, but there is now anti-sperm antibodies. So the sperm, well, we said that the sperm should have the capacity to move. I mean, remember I've told you that the movement is a better indicator of sperm quality than even the morphology. All right. So if now something is happening to the sperm cell that I cannot move, then that could be a problem. And that's where you have the anti-sperm antibodies. And the anti-sperm antibodies, these are antibodies that are now attaching themselves to the sperm cell that they are aggregating them. So if they are being aggregated, how can they move? Of course, movement becomes impeded. Once movement becomes impeded, it's automatically going to affect their fertility potential. All right. So we don't call it anti-sperm antibodies infertility. We rather call it autoimmune male infertility. And I'm saying so because autoimmune is when the body is producing antibodies against self, and sperms are part of the male body. Remember we said that along the line, you see, if you go back to your basic immunology, the body goes through self-recognition, even at the embryology state, where the body immunological system have a way of recognizing itself. So that every cell within the body recognizes it. The immune system recognizes it so that you know that this is part of me. All right. Now, remember we said that one feature about the reproductive system is that they don't function until after puberty. How about your cardiac system, your GIT system, all the systems of the body, they start functioning even from while they are fetus. They start functioning. But with the reproductive system, they don't function until after puberty. And so, and the output of this is the sperm. And the sperm too, one thing is that the sperm comes out also being haploid. So definitely the body sees the sperm as foreign. Technically, the body sees the sperm as foreign. And that's why it is important that the portion or the area where sperms are produced is kept so intact, controlled area. And that is where we have the Sertoli cells producing the blood testis barrier, where that it doesn't allow any contact with the immune system, for that matter, with the blood. Okay, and that's how come the Sertoli cells become so important, because if you are not allowing blood to come in, then the Sertoli cells may provide the nutrients, everything that the sperms will need. Okay, so that compartmentalization, when the sperms are kept enclosed without any contact, should be kept. However, we've seen that there are certain factors, there are certain things that can rather also attack the blood testis barrier. Remember, we said that there are certain toxins whose function is to attack the blood testis barrier. All they do, they weaken it. Once they weaken it, what they is that the semen, the sperms are becoming exposed, and then the sperm antigens are now going to be recognized by the immune system as foreign, and then they produce antibodies. Once they produce antibodies, some of the antibodies will go into the blood, of course, because they are produced by the immune system of the blood. Of course, a lot of them will be in the bloodstream. Okay, but there are also some that will also move into the site of production within the testes. Some of them and they bind to the sperms. So we say they are anti-sperm antibodies. They are bound anti-sperm. Look, if you do PSAs, and then I'm sure you know that you have a total PSA. You have bound form and then the free form. So even with the PSA, there are some which are bound to proteins. There are some which are free. So these are scientific listen that you should know as scientists. Okay, it is that knowledge that makes you proud, or not that, because a lot of these tests are now being done by automated machines, and therefore everybody thinks that, oh, as for this, anybody can do them. Yes, anybody can do it, but you need a certain quality of knowledge to be able to appreciate the outcome of what you're doing. Okay, otherwise, of course, anybody can do it because it's a machine. Just put in this and press here, press that. You don't need to be a graduate to do that. You don't need to hold PhD to do that. You understand? And that's where people think that, oh, even when they come to a lab, the certificate holder will tell you that even the work they are not doing anything. Yes, because they think that you are not doing anything. But the knowledge that you have is going to shaping the quality of your results. And that's the most important thing. Okay, so once the person who holds diploma and the person who holds degree and even above, there is a big difference in the knowledge gap. Okay, and it's this knowledge that makes you somebody and not the work that you're doing. All right, so please make sure that you are understanding some of these things very well and applying them in your workplaces. So what I'm saying is here is that, yes, sir.
Sorry, I wanted to ask this question.
Yes, please do.
The aggregation of the sperms we are talking of under the microscope.
Yeah.
How Is it that they are stuck together and they're not moving like clamps on it?
Okay,
Is
so
that the aggregation you
all
are
right.
talking about?
This is just by the information behind what you are going to do. Remember, you say you're going to do the step-by-step semen analysis. Okay.
Oh,
So once we go to the step-by-step methodologies, then all those things will come up. Okay. So you see that, so I'm just giving you some of these things so that once we get there, you remember that we started from somewhere. A lot of things that we are saying now, you're understanding them because I may have mentioned them on the different topics. Okay, now this is the right topic now. So, but you're understanding them, appreciating them because it may have been mentioned before. So once you go to the step-by-step semen analysis, then you appreciate some of all these things better. Okay, so don't worry, don't worry. Just make sure that you are going along with me. Okay, right. Thank you, thank you. So we're saying that the autoimmune, this is a condition that refers to improper bodily immune response against sperm antigens. Okay, resulting from disruption or breakdown of the blood-tested barrier due to genital tract infection or insults causing blah, blah, blah. So all that we're saying is that we expect the blood-tested barrier to be kept intact, okay? But there could be injury, and that injury can also jeopardize the integrity of the blood-tested barrier. For that matter, exposing the sperm antigens. Once that's done, then the immune system will also respond accordingly. However, we think that it is improper bodily immune response. How is it improper? The immune response, the immunity or the immune system is supposed to respond to anything foreign. Okay, but we call it improper because it's like it's going to go against itself. That's why we are saying improper. But if you look at it from the other angle, it means that the immune system is also doing its work very well because its work is to respond and react to anything which is foreign. Okay, so if you don't keep yourself well and you expose it, and now he's reacting, he said it's improper. And that's the element of the SLEs, systemic lupus erythematosus. I'm hoping that you know all those things on the hematology. Okay, the body is responding, but now you call them improper. Improper. How does it become improper? Once the body is responding to what it's supposed to be, to be performing its function of responding to immune foreign antibodies, or sorry, foreign antigens. That's just bad. So now you know that anti-sperm antibodies can come about. Okay, once they come about, they cause autoimmune male infertility. Autoimmune because the body will now produce antibodies against its own sperms. Okay, and that causes the sperm's inability to move. Okay, creating an infertility condition. All right, good. So, still information on the anti-sperm antibodies. We have, I said that some of the sperms, anti-sperm antibodies are found in the serum naturally. Some are in the seminal plasma. As we move along, we're going to talk about seminal plasma. And some are sperm bound. What it means is that we have some of the sperm, some of the antibodies binding to the sperms, and that's those that call the aggregations. Okay, we have some in the seminal plasma. We have some in the serum, but those that causes aggregation are those that are bound to the sperms. Okay, the sperm-bound anti-sperm antibodies are responsible for sperm agglutination, which interfere with sperm function and rendering the male infertile. Right. So we move further to diagnosis of male infertility. Laboratory investigations now still on semen analysis. So once we're going to deal with semen analysis, let's have a little information on what semen is. We know we've dealt with this already. So it's a recap. Now we're moving gradually into semen analysis. So what is semen? Semen can also be referred to as the seminal fluid. It has two major components, just as blood. If you have blood is a fluid, all right. It has two major components. It has the fluid portion and the cellular portion. Okay, when it comes to the cellular portion, then you know that even with the cellular portion, you have the buffy coat, you have the red cells, and the buffy coat. What is in the buffy coat? Yes, if you stream blood, what is in the buffy coat? Hello. Come again.
Platelet.
Platelets. Did you say platelets?
The white cells.
The white cells. On top of the buffy coat, you have the platelets. But the buffy coat itself is made up of the white cells. And then down there, you're going to get your red cells. Okay. So, but all of the, whether it's buffy coat or the red cell, that cellular component is, we can just call them blood cells. And then the fluid portion. So it has a semblance with the semen. Semen to can be separated into two major components. That's the fluid portion, then the cellular component or cellular portion. So before you can get the fluid portion and then the cellular portion, what must you do? If you have a semen, you want to separate it into two, the cellular portion and then the fluid portion. How are you going to do it?
Spin them.
Spinning. So it means that once you spin semen, you are going to separate it into the fluid portion and then the cellular portion. The fluid portion is called seminal plasma, just as we have with the blood. So the fluid portion is called seminal plasma, and then the cellular portion, of course, becomes your spermatozoa. All right. So it has that kind of semblance with blood. Okay. So now let's do a little more on the seminal plasma. So the seminal plasma, that's the fluid component of semen, is heterogeneous. When you say heterogeneous, what does it mean? When you say something heterogeneous.
It's not uniformly low.
From multiple sources. It's not from one source. So from multiple. So you know that the seminal plasma is coming from multiple sources. Okay, there are fluids coming from multiple sources, and those sources include the epididymis. Remember, we said that from the testes, within the seminiferous tubules, within the lumen, there's a lot of testicular fluid, because over there, the testicular sperms are completely immotile. They cannot move. So it is just a stream of fluid that is pushing them along through the straight seminiferous into the red testes, into the efferent tubules, and then to the epididymis. So, but we remember we said that one of the functions of the epididymis is to concentrate the sperms. What it means is that when we want to concentrate something, what it means is that some of the fluid portion will have to be taken away. If you have sugar in a cup of water, if you want it to be concentrated, what you do, you either add more sugar or try to take off some of the fluid of the water that you added. If you take some of the water that you added, but maintaining the same level of sugar, you see that now the remaining solution becomes more sugary or becomes concentrated. So what it means is that within the epididymis, the epididymis absorb a lot of the testicular fluid. Okay, because the sperm will have to be concentrated and be kept. Okay, so a lot of the testicular fluid is taken off. Meanwhile, after maturation, the sperms will have to be also protected. So the epididymis also produce a little amount of fluid. So the one that is going to be taken away virtually is devoid of the testicular fluid, but rather fluid from the epididymis, which is also very, very minimal. Okay, just to make it fluid for it to be able to now move up the vas deferens. Okay, so once you spin your semen, the fluid, the fluid which you call a seminal plasma, you can say that you can talk about a little from the epididymis, and then majority from the seminal vesicles, You have also some from the prostate gland, and then the bulbourethral glands. Okay, so you see that they are all coming from different sources and then come together to give you the composite fluid. All right, so seminal plasma is a heterogeneous composite fluid. That's what I'm talking about. Heterogeneous from various sources. Composite, that is to compose of a fluid. All right. Now we know already that the seminal vesicles give us about 60 to 70% of the semen, and this is making the biggest contributor to the semen fluid. This we know already. It's just a recap. And then we also know that 25 to 30% of the semen fluid is secreted by the prostate gland. This also we know already. And then we also know that just about less than 1% of the semen volume is produced by the bulbourethra or the corpus glands, which is usually released as a pre-ejaculate fluid to lubricate the lumen of the urethra. We know this already. So now you see that the seminal fluid volume reflects the secretory activity of the various accessory glands. So once you are talking about the seminal fluid, the fluid itself, you see that the sperm is coming from somewhere else, but the seminal plasma is a reflection of the secretory activities. So those that are being secreted, if there is inactivity, then the fluid component will suffer, not the cellular component. All right. So on the seminal plasma, it is important, very, very important. Elsewhere, we don't do this here, but here, like I keep on saying, we have to be able to build ourselves in such a way that we can find ourselves in anywhere elsewhere where they have the capacity, they have all the things that are available. Once you also have the knowledge, it's just a matter of now being able to do them. It is better that way than not having the knowledge at all. So that if you go out there and they do, let's say, seminal fructose, you don't know what the seminal fructose. They do prostate acid phosphatase, you don't know what it is. Then that becomes problematic. Okay, so we need to, and I'm sure that we mentioned this already, but let's now also capture it under the seminal plasma. So the plasma they consist of various biochemical components. And remember that the seminal fluid is coming from various sources. And all those various sources produce certain elements. All right. So those elements become markers of where they are coming from. Okay. So, for example, we know of PSA. The PSA is produced from the prostate. So if you're able to detect PSA, all right, then the PSA becomes a marker of the prostate gland. Okay, even though the PSA is still within the, it's like when you have blood, you have produce your serum. Okay, once you get your serum, and then let's say you are assessing, let's say anything, let's say albumin, for example, you know where albumin is coming from. Okay, so if albumin is going high, you know where to look at, where to look. When it's also going low, you should know. When your globulin is going high, you should know where it is coming. So similarly, you have the semen, you have span it, you have your seminal plasma, and then you are working on PSA. All right. So the PSA should tell you that the PSA level in there is showing an activity of the prostate. All right. So now you are looking at the prostate gland. Apart from the PSA, there are a lot of other things that can also be used to assess the activity of the prostate gland. And they include citric acid. And they also, citric acid is also very, very important, you see. I'm sure some of you may be actively doing microbiology. In the biochemical tests, you remember we have citrate tests, the biochemical acids, which is used to assess or identify specific organisms. You want to identify them, name the specific organism isolated. You do a lot of biochemical acids, and one of them is citrate. And you know that citrate you're talking about organisms that use citrate, and you know citrate is citric acid. I hope that you are not confused. They use the citrate as their source of energy. Meanwhile, a lot of organisms will use, let's say, any of the carbohydrates, your glucose, your lactose, and as your source of energy. But you also have certain organisms that use citrate as their source of energy. And so when you say it is citrate positive or citrate negative, it means that they are using, instead of using the ordinary glucose and stuff as their source of carbon, they are rather using citrate as their source of carbon. So it means that citrate is an energy source. Okay, citrate is an energy source. And like I'm saying, citrate is coming from citric acid. Citric acid is called citrate. All right, so it gives you idea that citric acid is one of the things that provide energy, and for that matter, nutrients for the sperm. All right. So, but you all know that apart from this, you also know about the fructose. But all of you are comfortable with fructose because fructose are one of the sugars. So you think that the only source of energy for the semen of the sperm is the fructose. But you know that citric acid is also a source of energy. All right. So you can talk about citrate. You can elsewhere, you can also measure citrate, seminal plasma or seminal citrate, which is the citric acid. And that is also coming from the prostate area. So PSA, prostate, zinc, then acid phosphatase. Remember when we were dealing with the PSAs on the prostate, we mentioned that acid phosphatase, before the coming into use of the PSA, the laboratory used acid phosphatase for assessing the activity of the prostate. So all doctors will also be requesting for acid phosphatase. Okay, but the thing is that acid phosphatase is not specific for the prostate. There are other sources that can also produce acid phosphatase. So if your serum acid phosphatase is high, you cannot exclusively relate it to the prostate, because other sources could also have it. All right. So in those days, there was what we call prostate-specific acid phosphatase. What it means is that there's also a means of assessing, for example, if you have total acid phosphatase, there is a means of detecting which portion is from the prostate. So we call it prostate acid phosphatase. I hope you are not confused. So we have the prostate acid phosphatase, and that is specific. Just like I don't have a good example now, but when it comes up, I will. But I hope that you are also understanding it. When you have serum, when you use the serum, and then you are getting acid phosphatase, if it is high, you cannot convincingly say that it is a problem with the prostate, because other sources come in. And I'm saying that within that same, just okay, as you have total bilirubin, okay, you can have total bilirubin, but you can have direct bilirubin and then indirect bilirubin. There's a way of assessing the direct bilirubin, and after that you can subtract from the total bilirubin to give you the indirect. Okay, so you have a means of also detecting the prostate acid phosphatase from the total acid phosphatase. That was when there was no PSA. But when PSA came, PSA was specific for prostate. Apart from the prostate, PSA has not been found in many places. So once your PSA is high, you say that you have a prostate problem. I'm hoping that that point is clear. So what I'm saying is that any of these entities any of these PSA, citric acid, zinc, acid phosphatase, any of them can be used as a biomarker for evaluating the prostate gland. Okay. When you come to fructose, seminal fructose, And then we also talk about prostaglandins. They can all be determined in the laboratory to assess as biomarkers for seminal vesicles. So that if you have the semen or the seminal fluid, you can spin it, and then the seminal plasma can now be used to check for, let's say, fructose level and then the prostaglandins level. All right, good. I'm sure that I told you that prostaglandin is coming from the seminal vesicles, but in the initial stages, previously, it was taught as coming from the prostate glands. Okay, this enzyme was thought to come from prostate glands, so it was called prostaglandins. All right. Then later on, it was realized that no, it was actually coming from the seminal vesicles. But now it's like the name has been established already, so scientists didn't touch it. So most times, people think that prostaglandins is come from the prostate. That was the original source. That was deemed to be the original source, but it is not. So take note of that. So prostaglandins is actually coming from the seminal vesicles. And then we are talking about the epididymis. We want to find out the sources of the seminal plasma. I mean, those parameters in the which elsewhere where they have the capacity, they are able to determine all these things. So free L-carnitine, glycerol phosphorylcholine, and then neutral glucosidase. These are all entities that can be measured from the seminal plasma, and each of them will indicate where it is coming from, and therefore can be used as biomarkers for those. Okay. Right. Remember, we said that the seminal plasma is also providing nourishment. And the nourishment, all of us are aware of the fructose. But we've just mentioned of the citric acid, which is from the prostate. Citric acid is citrate, and it's also a source of energy. So they provide the nourishment. Then seminal plasma is also providing protection. Okay, I'll explain more on the protection in the next point. And they also act as buffer as well as transport medium for the sperm. So we're just trying to give more detailed information about the seminal plasma. Okay, right. But when you are dealing with semen, as we move along, when you are dealing with semen, you don't, it's like when you are dealing with blood. You are not going to separate the plasma from, or the serum from the blood cells. That becomes a whole blood. Similarly, if you are dealing with semen, I'm not saying that go and separate the semen into plasma and this thing. No, it's saying that the semen has those two components, the fluid portion and then the semen. When you are dealing with them, you are not going to separate them. All right. Now, the only time you separate them is, when you go to the step-by-step processing. You know that at a point you are going to spin them. You are going to spin the seminal fluid, and for that matter, the semen. You're going to spin it. All right. And when we get there, you know why you spin the semen, and what will we be looking for. Okay. All right. So on the issue of protection, the seminal fluid, the seminal plasma has a lot of enzymatic antioxidants. Remember that we've said that one of the things that actually destroy sperms very well is the oxidative stress, the reactive oxygen species. And I think now we know a lot about the reactive oxygen species. And we said that they only become oxidative stress when the body has its own antioxidants to mop up the excess reactive oxygen species. Unfortunately, most of the time, we don't have enough of the antioxidants to be able to neutralize the reactive oxygen. So there's always a negative balance, and that creates the oxidative stress. This oxidative stress is a destroyer. I mean, people are even saying that that is what causes aging. So, now people, if you want to reduce the way you are aging, you have to take in a lot of antioxidants. That is what people are claiming, but I have no basis to challenge that one. So the seminal plasma also contains a lot of antioxidants, including glutathione peroxidase, including peroxide dismutase, and I'm sure a lot, especially those of you in microbiology, know catalase. Catalase, remember, hydrogen peroxide. Remember, the hydrogen peroxide is also one of the reactive oxygen species. So catalase is able to break down hydrogen peroxide into water and oxygen. Okay, right. So it means that catalase is now becoming an antioxidant because the A2O2, which is one of the reactive oxygen species, will now be neutralized under the effect of a catalase. Catalase will break down the A2O2 to water and oxygen. Water is neutral. Oxygen, normal oxygen too, is also fine. So now it means that the negative effect of the A2O2 will have been neutralized. Okay, right. So, and all those things are present in the seminal plasma. And once they are there, it means that they are protecting the sperm against the any excess reactive oxygen species, and for that matter, oxidative stress. Okay, so those are the enzymes. There are also non-enzymatic antioxidants, and the common non-enzymatic antioxidants are vitamin C. Vitamin C is not an enzyme. Okay, right. And then vitamin E and zinc. And remember, the zinc present in the seminal plasma is acting as an antioxidant. And once they are acting as antioxidant, it means that they are protecting the sperm. And remember, we said that antioxidants, one of their targets is to damage proteins. And then here, when it comes to the sperm, their target is rather on the DNA. And the DNA is in the nucleus. That actually stands for the genetic material. So they destroy it. So you do your semen, all right, everything appears okay. However, so once we move along, you are going to talk about the limitations of semen analysis. The semen analysis, if the DNA has been fragmented or has been injured, the semen analysis may not be able to detect it. Okay. Meanwhile, the seminal plasma contains a lot of proteins or enzymes and non-enzymes that is supposed to be protecting the DNA, and therefore to keep the sperm in a healthy position. Okay, so that is the role of the seminal plasma. All right, so seminal plasma also has a lot of protein that play an integral role in keeping sperm in a decapitated state. Remember, we said that when we are dealing with the structure of the morphology of the sperms, we talked about the acrosome, and we said that the acrosome plays a role in causing what we call capacitation. And we said that capacitation is where once the sperm meets the egg in the fallopian tube, the acrosome is coming from the Golgi apparatus. The Golgi apparatus contains lysozymes, which are hydrolytic and proteolytic. They are able to break down, they contain hyaluronidase. I always have difficulty in mentioning that. They are proteolytic and hydrolytic. They break down a lot of things. And so what they do is that once they hit once they get to the egg has an outer shell, a certain shell called the zona pellucidum. This zona pellucidum, it is the acrosome which will now break and release its hydrolytic enzymes to try to create a hole I mean, where they hit the zona, then they will release the acrosomal enzymes. Okay, and then that will also cause some kind of opening in there so that the head can now, the nucleus, for that matter, the genetic material will now infuse into the egg to fertilize it. So you see that without capacitation, fertilization will not take place. Okay, and what the seminal plasma does is to make sure that the head, and for that matter, the acrosome doesn't break while it is still within the male tract. I hope that you are following it. So the whole thing is called capacitation. Okay, capable, so that once the acrosome begins to react, then it is creating a problem. Meanwhile, the acrosome is not supposed to break while it is still within the genital tract, within the male genital tract, and even whilst it is within the female tract, it's not supposed to break until it has met the egg. Once it meets the egg, now okay, you are free to do whatever you want to do. So it is the seminal plasma. They contain certain proteins that are able to hold the acrosome in check so that it doesn't misbehave. It doesn't cause its reaction. Okay, and so decapitate means removing the capacity. Remember we said that the prefix de means remove. Okay, remove. So capacitate means now being capable, and then it creates what we call hypermotility. So during the capacitation stage, the sperm becomes hypermotile, becomes strongly moving, strongly very hard, and that is it's like drilling the zona pellucidity, that's the outer lining of the egg. Okay, so all that we are saying here is that whilst the sperm has not reached the egg, its movement is still controlled by the seminal plasma. And the seminal plasma contains certain proteins that is holding the acrosome in check. That massa, your time is not up to cause any reaction. Make sure you don't do this. And that's called decapacitation. Okay, and so once the seminal plasma does this, it means that it's also protecting the sperm. Okay, so it is the capacity of the seminal plasma to hold the acrosome in check until the right time, and thus preventing premature onset of capacitation. I hope it's complex, but I'm hoping that I'm trying my best to explain it. I'm hoping that you are following it. That whilst the sperm is still within the genital tract, both in the male and then the female, it will not cause capacitation. Remember that in the absence of capacitation, fertilization will never take place. There shall never be any fertilization without capacitation. And the capacitation is that acrosomal reaction which will cause the acrosome to break and then release its enzymes, which will now cause, lytic means breaking, will break the wall of the eggshell for it to be able to enter. If that doesn't happen, there's no way the egg is going to naturally, because now you know that we have the artificial system where you even have the ICSI, the intracytoplasmic sperm injection, where now artificially the sperm is going to be injected straight away into the egg by force. So that is the intracytoplasmic sperm injection, that one. So you don't need any acrosome, so that even if the acrosome is destroyed, all we need is that we need a genetic material. The genetic material will now be artificially introduced into the egg, and that is one of the technologies in the artificial reproductive technology that is currently available. Okay, so this is the kind of things that as scientists, you should have a fair idea, even though, yes, you are going to do some analysis, but you have to know the significant role the seminal plasma is playing that contains a lot of proteins that keep the sperm, and for that matter, the acrosome in check, so that it does not react until the right time, until it has met the egg. Okay, now that phenomena is called decapacitation. It is not allowing you to capacitate, and so that's the decapacitated state. Hold that point. Then, of course, finally we have the spermatozoa, which is the cellular component making up 1 to 5% of the seminal fluid. Just as if you have blood, okay, anticoagulated blood, and then you spin, you are going to get your the sedimental red cells, okay, and then of course you get your plasma, and you can assess what percentage of the red cell is being sedimented, and then that will give you the PCV, packed cell volume. You remember that in hematology, these are fundamentals. So these are all that. So what I'm saying is that if you have semen and you spin, the cell component, the cellular component will give you just about 1 to 5% of the entire seminal volume. Okay, all right. So this is a summary of the things that are within the seminal plasma. Okay, all the things that you said. This slide is showing the summary of it. So let's try to now move gradually to the semen analysis. Okay, gradually semen analysis, but still we are not even up to the step-by-step. We are still not up to the step-by-step. We have some 15 minutes. Let's see what we can do a little bit before we move in. So semen analysis, it can also be called the seminogram. It can also be called the spermiogram. So depending on some, I'm bringing all these things up because sometimes, especially the old doctors, they are used to seminogram and spermiogram. So you can have a request coming to spermiogram and then you wouldn't know what is it, and then you'll be confused. But spermiogram, seminogram is all the same as semen analysis. Okay, and it said it's the single most important first step of investigations or evaluation of male infertility. We know this as a fact. Semen analysis is a routine test for infertility. Take note of this. It's a routine test for infertility. Routine test means like the basic test that we do for infertility. It cannot be a routine test for fertility. Okay, it cannot be a routine test for fertility. It's rather a routine test for infertility. It helps to determine if there are any issues with the sperm, and that may be causing infertility. It is used to evaluate the quality and quantity of sperm. For example, you'll be dealing with the sperm count, motility, viability, and so forth and so on. All right. And all these things can now be used to assess the fertility potential of the man. Okay. Now, why do you do semen analysis? Why do you do semen analysis? Is it just for the fertility? So this will now open your eye to say, oh, so semen analysis can be done for a lot of reasons. So I capture this as either the clinical significance, that's the importance, the clinical importance of semen analysis, or indications, that is why when you say something is indicative, what will cause semen analysis to be done, or the usefulness of semen analysis, or reason for semen analysis. So any of this still is under reasons why we do semen analysis. The clinical significance or importance of semen analysis, indications for semen analysis, the usefulness or reason for semen analysis. So a routine semen analysis is important for a number of reasons. One, appraisal of fertility potential. That's the thing all of us know. Where there is a failure of a couple to conceive naturally after 1 year of unprotected sex, a semen analysis will be needed to help rule in or rule out. I hope that by now you also understand this simple terminology, rule in and rule out. Okay, so you do it to rule in or to rule out the potential. So that's the thing almost everybody does. That's all people know about fertility potential. Sorry, about semen analysis. Use it to appraise the fertility potential. All right, but there are a lot of things that can be done. Determination of effectiveness of vasectomy. Remember, we said that the vas deferens can be severed or can be cut. All right, there are some men who want to, let's say they have had their children, they don't want to have any more children, and they don't also want to worry their women. It's always the women who go in for contraception or contraceptive technologies. Say, okay, my wife, I don't want to worry you, so let me go and do this procedure. When you call it vasectomy, we know this already. All right. So once you do vasectomy, it doesn't end there. There must be a test which will prove that the vasectomy has actually been successful. Okay. And the test is post-vasectomy semen analysis, PVSA. So here, normally under the appraisal for fertility, you pray that there should be sperms in the semen. Okay, you want to pray that, but with the vasectomy, your motive is to make sure that there's no sperm in the semen. Okay, there should be no sperm. So whilst in the appraisal form, you want to you pray that there should be sperm. In this one, in the post-vasectomy semen analysis, your prayer is that there should be no sperm. And remember, once there is no sperm in semen, it is supposed to be a test for sterility. Sterile means that you cannot give birth. You don't have the sperm to go and do any fertilization. So that is. So you also may do semen analysis as a follow-up check for after vasectomy. Okay, and this is called PVSA, post-vasectomy semen analysis. So if you may be there and then a doctor requests for PVSA, then yes, you should know what it is. The person has gone to do vasectomy and they want to find out. And in all these things, you do more work on it. In post-vasectomy semen analysis, there are certain things that must also be looked out for. Okay, right. When to do it and when not to do it. Okay, I'll deal with it more on that as we move along. So we also do semen analysis to find out, to determine the effectiveness of the vasectomy. Okay, in this case, when you do it, you don't expect to see any sperm. Once there's no sperm, it means that the person has passed it, meaning the procedure has been successful. Okay, right. But it is not as simple as that. In the next few slides, you will see what you must do. Then there's also, you remember we mentioned about vasovasostomy, where we said that there could be a reversal of, and then we call it anastomosis, reanastomosis, when the vas has been cut. Okay, this end is sealed, this end is sealed. Now, the person now, after some years, so no, I've got a new girlfriend, I've got a new wife. He thinks that we should have a child, so I want the vasectomy to be reversed. That's called vasectomy reversal. And it's vasovasostomy because it is one end of the vas deferens and the other end of the vas deferens which is going to be joined together. So it becomes vasovasostomy. Okay, I think I explained that when we were doing the vasectomy. Okay, so in that case, you expect that the semen parameters should also become normalized. Okay, so the first one is to check whether the vasectomy was okay. And then in vasectomy, you're also talking about a situation where there are doing vasectomy reversal. And you also want to check up whether now there are adequate numbers of sperms in the distance. Okay, Okay, following restoration. All right, so this is also another idea. There's screening male donors for sperm donation. Remember, these days it has become a market where, because of the ARTs, artificial reproductive technologies that are available, people go and donate sperms. Okay, people go and donate and take their money. It's like in the blood bank system. Some people these days, I think, with the voluntary blood donation, I think those commercial blood donors have minimized. But still, they are there. People go and take money to go and donate for people. But you don't. You must pass the requirement to be able to donate your blood. Similarly, you should be able to meet. You don't go in to say, I'm coming to donate my sperm and take money. You go now. You know they have a sperm bank. What if your semen cry? What if your semen cry doesn't contain anything? If your semen cry is oligo, then you go. So it means that the semen analysis are now also becoming a screening test to screen sperm donors. All right. So it's not about marriage. It's not about anything. The person wants to go and donate sperms to take money, and then that now it has become a very huge market. Sperm donors. But what I'm saying that before they take they must make sure that your semen has adequate sperms. And so in that case, you do semen analysis. All right. Then another way to assessment of male reproductive function and genital tract patency. When you say patency, it means that as a condom, I mean, it's like sometimes they block certain ways, say no thorough way, no thoroughfare. It's like you can't pass through. You see, sometimes somebody may have gone to do some operation, and I think that probably some part of the genital tract may have been severed or something. So we want to go and do semen analysis to make sure that, because once you do semen analysis, it tells you that from the production site through the tract, through the passageway out to outside, everything upon them. Okay, so it is also possible to go that way. All right, they are doing the semen analysis. Once you do the semen analysis and everything's coming out, I mean, it means that there's nothing wrong with the passageway, with your production to the passageway. There's nothing wrong. Okay, so that can also be done. So a male who has congenital abnormality and with strong suspicion of pathology in the male reproductive system may require semen examination to enable appropriate treatment. So here we are saying that the patient knows that he has an abnormality. If, let's say, he is somebody who has undecided testicles, he knows it. And then probably there has been some treatment. We want to find out whether the thing has now worked. Okay, so that's also an assessment of the reproductive function. All right. Then paternity testing. Paternity testing to support or disprove a denial of paternity on the grounds of sterility. Somebody says that you have impregnated me. Say me, I'm sterile. I've done vasectomy. So if you say that I'm the father of it is not possible. So sometimes the doctor without these days, because of the DNAs. But before you go and do it, sometimes some of these simple tests can be done. Okay, so you say that you are sterile. Go and do semen analysis and let's find out. You go and do semen analysis and indeed there's nothing there. So the man is actually sterile, and therefore you could not have fathered your child. Okay, something like that. So it also becomes for paternity. There's also forensic investigations. That's medical legal purposes. In the case of alleged rape or sexual assault, vaginal secretions or clothing stains or material obtained is tested for demonstration of semen. Here, you are not doing the semen analysis, the routine semen analysis that you'll be taken to. But those in the forensic science area, all right, somebody said he had been raped, and there should be an evidence. So if they're able to pick some secretions, it could even be dried secretions in the clothes or something, or in the vaginal area or something have been picked up. It goes for forensic investigation. And here you have to test for the fact that whatever was there is actually semen. Now you don't necessarily have to see the sperms. And that's where here you are going to now check for some of the components that we described in the seminal plasma. Okay, because even here, if the person had already done vasectomy, you know that he's sterile. That's why he's raping people around. And you know, if you want to demonstrate, if you want to find out whether there's sperm there, the person is sterile. Where are you? Or even the person is exospermic. How are you going to get a sperm? Sometimes some doctors, somebody goes to request for rape, complaints about rape or sexual assault. They say go and do HVS and find out sperm. What if the person is exospermic? Where are you going to see the sperm? So sometimes rather they take some swab from there, and then they must find out the semen. Okay, and semen, you just want to use some of the biomarkers, and here the most significant biomarker is the prostatic acid phosphatase. Remember, we said that the prostate, you have the PSA, you also have the prostatic acid phosphatase. Okay, and any of these tests can be used as soon as, because the vagina doesn't, if the swab is from the vagina doesn't produce acid phosphatase. Okay, so the acid, if the swab from the vagina from an alleged rape case is showing a positive test for prostatic acid phosphatase, then that could confirm that yes, there's semen there. Not necessarily sperms. You don't have to demonstrate sperm, because the person, if it's sterile or azoospermia, you are not going to see the sperm there. So as scientists, I know some of our colleagues are in the forensic science space. Okay, and these are the things that we do. All right, so this is very important. There's something which is happening in our labs, very, very, very disturbing, and the next slide will show you. All right, still on the forensic investigations, you see that I've said that the two biomarkers that are significant with the semen is the acid phosphatase. So we have the prostatic acid phosphatase, and we also have our normal PSA. Okay, PSA is also called the prostatic P30. Okay, the P30. Now you have a kit called the P30 test kit, and people are using it to check for PSA in the labs. That's so unfortunate. So unfortunate. Just as we mentioned, when we were doing the TP strips. Remember when we were doing the TP strips, we came to learn that the TP strips are specific. They are specific treponema tests, and they're usually based on immunochromatography. And these are, from a chemical perspective, they are very, very specific. P30 is a test for PSA. And the P30 test kit is immunochromatographic. These are supposed to be used in forensic science, where you're only testing whether there is a P30 or not. And P30, I'm saying here, P30 is PSA. Take note. The P30 is prostatic specific antigen. P30 is the same thing. And it's based on the immunochromatographic. It's just a matter, even if the patient, there are some dried secretions in the cloth, all you need to do is to try to get that thing, that dissolved a little bit and make it a solution, and just put in a strip. The strip will show that it's positive. or you just know that there is PSA, not the level. Remember, in our normal PSAs, you are not testing whether it is not qualitative. You know, when you are doing qualitative tests, it says it's positive or negative. Quantitative tests, you want to know how much it is, how much is there. So if people are using P30 test kit to check for PSA, then I ask myself, what sort of science are we doing? Because the P30 test kit will tell you that it's just like you doing the pregnancy test or doing the syphilis, so-called syphilis strip test. It's just that it will give you the band. Once the band is there, it's a positive. But in the serum PSA, it is not about whether it's positive or negative. It is about a certain level. Okay, it's about a certain level so that the fact that there is PSA in there doesn't mean that the person has a problem. But it is the quantity of it that determines whether the person has a problem with the PSA or so the person has a problem with the prostate or not. So you can't use the P-test kit and say that the person has PSA and therefore he should be going for treatment. This P30 test kit, take this from me, is supposed to detect the presence of PSA, especially in semen, especially and for forensic investigations purposes. Because over there, the case matter, I mean, the incident may have done and gone, and then you are just want to find a certain evidence. So the person says, oh, okay, yeah, he raped me. If you could go not necessarily in the vaginal area, but sometimes because the person was screaming and somebody was coming, he just withdrawn, and then the thing even didn't go into the vagina, but on the bed or even on the rest. Once you're able to take some of those things, guess your lab, use the P30. The P30 says positive. One P30 says the P30 is PSA, and PSA is coming from the prostate. And once you have it that way, it can confirm that what they saw on the clothes or on the bed or on the thighs of this woman is tested to be semen. That's all. So please, those of you who are using the P30 test kit to check for serum PSA, I'm sorry. Sorry, it is a wrong approach. All right. So the presence of P30 can confirm semen in cases where spermatozoa are absent, such as in vasectomized individual. Like we said, over there, in the case of rape, you don't rely on the presence of spermatozoa because, like I've said over and over again, somebody may have been vasectomized and therefore is sterile. But once you are sterile, that doesn't mean that you cannot ejaculate. You can ejaculate and produce your seminal fluid or your semen, all right, except that semen doesn't contain any sperms. All right, good. So the next time is follow up of fertility. If let's say somebody has undergone cancer treatment, all right. Once it's finished with the cancer treatment, it's fine because chemotherapy, all of us know that they also affect sperm production. All right, the radiations and all those, they can all affect. So sometimes the person has undergone cancer treatment. Once it's finished, you want to find out whether it has affected the person's reproductive organs. All right, so it goes to do the semen analysis, not necessarily for childbirth, but just to make sure that he has. So, and then also a measure of efficacy of male contraception. And this is just also like the vasectomy. But you see here, we're talking about a situation where people are not necessarily going vasectomy, but they are taking some hormonal contraceptive pills, just as the women. There are also the male components where people are taking hormones. And then we want to assess the efficacy of that. So these are the reasons why we do semen analysis. And I'm sure that you have learned something out of it. All right, so tomorrow we are not meeting, you meet on Thursday, but rather we also meet on Saturday. Or do you want tomorrow and Thursday, or you want Thursday and Saturday? So that I can see what to do.
Tomorrow and Thursday.
Do you want tomorrow and Thursday or Thursday
and
Saturday?
Tomorrow and Thursday.
Tomorrow Thursday.
Come again. Tomorrow and Thursday.
Tomorrow and Thursday. Yes.
Okay. All right.
Yes,
Grandpa,
please.
Yes, sir.
Please, I think with this one, can we, give it a form of a vote on the platform so that the majority will carry the vote?
All right. Okay. I'll go for that. So let's so that by tomorrow morning we should be able to know whether you are doing tomorrow and Thursday, or you are doing. I just want to make time for what we missed yesterday. Okay, and the yesterday one, as for Thursday, is constant because the original listing is Monday, Tuesdays, and Thursdays. The Monday one, which we conveniently miss, we want to fix it either tomorrow or Saturday. This is where I'm coming from. So either we make it tomorrow or Saturday. As for Thursday one, it is constant. So we, as you suggested, I'll go by that one. We are going to vote, and the vote will end by tomorrow by 8 because I should know whether it is coming on or not. If I know it's coming on, then when I go out, I know that I have to come home early. Okay. So by 8 a.m., you should be, even if only 2 people have voted on it, we will take it. Is that all right?
Yes, please.
Yes, Grandpa.
Okay.
Grandpa, please, I think there's a question in the comment section.
Okay, let me take it. All right, so what sample will be for a female? Normally, I brought this one up because I know that some of our scientists are in forensic science space. And I also am aware that people are using the P30 test kit for normal PSA check. That is why I brought in the element of the forensic. Now, if there's a rape, what I know when I was at work, a lot of time doctors will request for HVS, and over there they are looking for sperms. And sometimes I laugh. You may get the sperm, you may do the HVS and get a sperm, fine, but the fact that you do HVS, you don't get a sperm doesn't mean that the rape did not occur or occurred. Now you want to do a test that will be shown as evidence that yes, somebody has raped, or there is some evidence of it. So if the woman can know that yes, I mean, yes, I could feel that he ejaculated. That one, especially if the patient, for as long as the patient has not, because sometimes the mistake is that the thing probably occurred about 3 days ago. He has even bathed 2 or 3 times already. So what are you going to get in there in the first place? You are not going to get anything at all. But where it is fresh, you are looking for any secretions that could likely be coming from the rapist. Okay, so if it's in the vagina, fine, and the patient has not bathed or has not washed that area, you could take a swab. All you do is that once you take a swab, you are going to, the simplest one is the P30, because the prostatic acid phosphatase, you have to do an ELISA test. You have to do ELISA, and how many people want to do ELISA? Okay, but the P30 test has become like normal test strip, like the one that people are doing for pregnancy tests, the P30. So if you take a swab, HVS, a vaginal swab, just make it as though you are making an emulsion, just a little amount in water. And then once you have made that suspension, just dip in the P30 test kit. And if it shows 2 bands, of course, it means that it's positive. Then you report that P30 positive. And P30 positive means that there's PSA. And once there's PSA, it means that there's seminal plasma. Okay, so that is how it is. And sometimes may not necessarily be in the vagina. Sometimes it could even be from the bed, because sometimes the raping is not a smooth thing. It's just so sometimes that doesn't mean that I've done some before. Please, I haven't done some before. But I know that rape will not be a smooth thing. So probably in the term of the person being run away, some of the ejaculate probably may have spilled on the floor or on the bed. If the patient can the alleged rape lady could show that evidence, then that secretion on the bed or on the food or whatever can be collected and then be moved, be prepared as a suspension and then test for the P30. So the P30 has now superseded the prostatic acid phosphatase. The prostatic acid phosphatase will have to be done in a real lab where there is ELISA technique available for the prostatic acid phosphatase. But of course, all you and I know that it is better to it is faster and more convenient to be using the P30. And that's what everybody is doing. So any sample that can be obtained, it can be from the woman, it can be from anywhere, can be used for that test. All right. There was agreement senior. It's not rape. I don't know. What is this? Okay, let me. Okay. Vaginal cervical area swab, swab's blood. Look up for DNA. I don't know whether this one.
How can this be rape? You have time to
Vaginal
wear
cervical
condom to
swab,
rape.
oral swab, survivor's blood or saliva to look up for DNA. This one, I don't know about it. I don't know about it. Sorry. Of course, I cannot. I'm not a forensic scientist, but all that I try to bring in is the element of the fact that semen, especially seminal plasma, can be a useful medium for investigating rape. Okay, and I'm saying that under that circumstance, just any trace of the seminal secretions, any trace can be where it can be obtained from either from the woman or even on the part of the body or on the bed or in any part of the room. For a long run, I can say that okay, the man was running away, but even as he was running away, you could I could see some of the semen dripping on the floor. If it can be shown and can be collected, it can easily be sent to a forensic laboratory, not in the clinical lab. The clinical lab, what we do is just clinical testing, and forensic has a different way of doing their things. Now, all that I've said over again is the fact that I know that people are using the P30, and I've said the P30 is PSA. And this is what people are using to test for the routine PSA that is supposed to be there in the blood. And I'm saying that is very unfortunate. All right. I had a case last week, and the young girl said the man used a condom. In such cases, what can you advise? Okay, this is actually a forensic area. Okay, so you may have to seek advice from the forensic experts. But if the man use condom, the game is the whole thing is about evidence. So if the man used condom and that condom was taken away by the man, it means that you have nothing to show. You have nothing to show, and because this time you see, some people even rape. What do you call it? Underage people, and doctors are having it difficult to prove it because these days, even though that the young girl, you suspect that you have the hymen there. A lot of them, the hymen is already broken, and you examine, then you are not seeing anything to use as evidence. Okay, and sometimes some of the people are able to get their way scot-free because you can prove. So if the man use condom and there's no evidence, I'm sure the forensic scientists will be in a better position to give advice as to what to do. All right. Let me. Okay, all right. I think you are understanding things already yourself. So please, so in rape investigation, can you do the ABS and use the suspension to test for? Oh yes, yes. If you have the P test, the P30, you if you do the ABS, two things. You can do the ABS and look for the sperm. That one, if you get it, that's more evidential. Okay, especially if there's a sperm. Okay, and then but we are talking about a situation where there's a situation where the person himself is azoospermic, or probably has undergone vasectomy, two things. So the semen will come out right if you want to use the sperm as a basis for confirming the rape. That one, there a lot of people will go scot-free. But if you also have the P30, then that is very, very. So you can do the HVS, do the microscopy, and even do gram stain, because sometimes you see the gram staining may show, and as we move along, you see you are going to do gram stain of sperm and how they appear. All right. You can see the head, and the tail will be lost during the staining procedure. But you should know how the head is detected or can be identified. Right. So if you are able to identify the presence of a sperm, that is fine. And then if you also have the P test kit, and then you also do, then it means that it's like assurance double sure. You're confirming beyond reasonable doubt that the person is positive. But if you do the HBS and then the microscopy and gram stain show nothing, that doesn't make the man go scot-free. If you have the P test, then the P test will now also show positive, and then you can say that the P test was positive, and therefore, but then the question becomes that if what is the indication that the semen there is me? Because now you are saying that it's me, and then you are saying that okay, you did a certain P test. What shows that it's me? Okay, that's where probably other tests can go. You can now go and do the profiling. That you do whatever was taken there. The patient will have to be now the alleged rapist will now be forced to produce semen, and then they do a DNA typing to find out whether what was found in the woman in the vagina or in that ABS tallies with what the man is now producing. Otherwise, the man can also get a good lawyer and go scot-free. Okay, so those are some of the things that I can say for now. All right. Thank you. So, God willing, tomorrow we're going to do more on the purposes of checking the effectiveness of vasectomy. All right. Remember, we are still not into semen analysis yet. But before we get there, you know that we'll have gotten a lot of information as we move along. All right. Okay. Any question, please? Okay, there's another one on the chat. Let me see. Oh, so the sample in rape, usually they take the ABS. Usually they take ABS. But what I'm saying here is that when you take the ABS, what we are normally looking out for is the sperm. What if the man is azoospermic? So you see sperm, and therefore the person, he didn't chop the thing. He didn't chop. There was no sperm. So no sperm. Therefore, the person should go scot-free. Yeah, because there's no sperm. But what I'm saying that mostly, and even people, some people may even have had the P30 test kit, but they don't know that it is actually designed for some of these things. Not even for some of these. These are designed for forensic investigations like this one. So they use the P30 for normal PSA tests. And once there is even a rape case, they don't even know that it is for this purpose that you have the P test. How that you're getting me? All right. So people, unless now you have this education, people will not even consider the P test at all. Okay. And the basis of the P test is the fact that the P test checks for prostatic specific antigen, which is a key biomarker from the prostate, which is also a composite of the semen, seminal fluid. All right. So once you're able to detect its presence, it means that seminal fluid has been there. And once seminal fluid has been there, whatever mean, why did they get there? It got there because already the person is saying that they have been raped. Then it is there. Then the question is, how can we also confirm that that semen is my semen? Okay, that's where the trust of the matter also comes in. Yes, you have gone to do your HVS, you have checked it, it is there, yes. What shows that it is my semen? Mm-hmm. Anyway, that's just by the way. So call it a day. Tomorrow, God willing, we meet. And if there's no question,
No, please, there's a question in the session.
In the
comment section.
Comment section. Comment section. Where, please? I thought I've.
The name of the questioner is Emmanuel K. M. Nati.
For the beginning of the lecture, you mentioned the regular sexual intercourse. How often should
How about this question? There's too much.
Oh, as often as your health can manage. You see, we are talking about it because and you remember we talked even about the sexual habit where people can they are staying with their woman. They don't even know the person's ovulation period. And so as and when they have a desire to have sex, they have it. Meanwhile, your purpose, your intention is to have conception. All right. So if you have no knowledge at all, you'll be having the sex, all right, but probably it's off guard. So regularly, well, if you can do it 3-4 times a week, I think it's not bad. 3-4 times a week, it's not bad. If you can also make it daily, fine. But I don't know how you can manage that one every day. All right. So, but we want to establish the fact that definition of infertility is not the fact that you have married for 5 years. So, if you are married for 5 years and the two of you are staying elsewhere and occasionally you come one by one, that doesn't meet the definition for infertility. I just wanted you to know that yes, we have a baseline, a time limit of at least 1 year, but within that 1 year, there should be that kind of regular affair as much as possible. Okay, and not that you are staying somewhere and then occasionally you also come for a weekend and go. What if that weekend you came, no, the ovulation has already passed? Then you said, oh, we have been having sex, but your timing is wrong. So you need to have all these things. It's not for our own interest, but for the fact that you also be in a very good position to advise your clients or patients scientifically. You don't want a situation where you be given a certain information and a certain doctor also give information completely different. And then you say, who told you this? You don't want a situation where they say, who told you this? So the last scientist told me this. So the last time, then it's done well because that is exactly the case. And then you see that you get your applause. Okay. From the beginning, let me see. There's regular itself is good for the person. Hey, Class P, Kingsley. I said that the regular itself is good for the prostate and the cardio. That's not bad. So as for the regular, it has to be. It has to be, especially when you have been married for the first 1 year. As for regular, it has to be regular. It has to be regular. It has to be regular. All right. It's been interesting, eh? All right. Any other contribution or any other point? As we continue tomorrow. Hey, that's it tomorrow. Okay, we may continue tomorrow depending on the outcome of what you all agree. See you tomorrow or Thursday or whatever. Let me see. There's another. Okay. Good night.
Good night.